Nephrolithiasis begins when urine becomes supersaturated with stone-forming salts, leading to the precipitation of solid crystals.
Once nucleation occurs, these microscopic crystals aggregate, forming a nidus for further mineral deposition.
Calcium oxalate stones are the most common, characterized by their sharp, jagged spicules that cause direct tissue trauma.
Uric acid stones thrive in acidic environments and are often radiolucent, making them difficult to detect on standard X-rays.
Rare genetic conditions like cystinuria lead to the formation of waxy, hexagonal stones that are notoriously difficult to treat.
Identifying the chemical composition of a stone is critical for determining the most effective prevention and treatment plan.
As stones migrate from the kidney, they frequently impact at anatomical narrowings, most notably the ureteropelvic junction. This sudden blockage causes an immediate rise in proximal pressure, stretching the ureteral wall and triggering intense pain signals. This sudden blockage causes an immediate rise in proximal pressure, stretching the ureteral wall and triggering intense pain signals.
As stones migrate from the kidney, they frequently impact at anatomical narrowings, most notably the ureteropelvic junction.
This sudden blockage causes an immediate rise in proximal pressure, stretching the ureteral wall and triggering intense pain signals.
The ureter undergoes forceful, spasmodic contractions to dislodge the obstruction, manifesting as the excruciating waves of renal colic.
If the stone remains lodged, the retrograde buildup of urine causes the renal pelvis and calyces to dilate. The localized tissue injury triggers the release of prostaglandins, which further increases renal blood flow and pressure within the kidney. The jagged edges of the stone abrade the delicate epithelial lining, leading to the presence of blood in the urine, or hematuria.
In chronic cases, stones can grow into Staghorn calculi, filling the entire renal collecting system and compromising kidney function.
Struvite stones are formed by urease-producing bacteria, creating a vicious cycle of recurrent infections and rapid stone growth.
A blocked and infected kidney can lead to pyonephrosis, a surgical emergency where pus accumulates within the renal pelvis.
Long-term untreated obstruction results in the thinning of the renal cortex and permanent loss of functional nephrons.
Underlying metabolic issues, such as hyperparathyroidism, can lead to the continuous formation of multiple renal stones.
A thorough metabolic evaluation, including a 24-hour urine analysis, is essential to identify the root cause of stone formation. Advanced endoscopic techniques allow for laser lithotripsy, where high-energy lasers pulverize stones into dust for safe passage.
Non-invasive extracorporeal shockwave lithotripsy uses focused acoustic energy to fragment stones without a single incision.
Maintaining high fluid intake remains the gold standard for preventing the supersaturation of urine and ensuring long-term renal health.